Morning, everybody. I'd like to welcome you today to today's webinar on managing the gut in autism by Dr. Arthur Krigsman. And this is a presentation of the Brain Foundation, whose mission is to catalyze science and translational research, leading to FDA-approved treatments to benefit individuals with neurodevelopmental disorders, including ASD. If you'd like to know more about the organization or sign up for our information, please go to our website, brainfoundation.org. So let's welcome Dr. Krigsman. Dr. Krigsman is a pediatrician and pediatric gastroenterologist with expertise in the evaluation and treatment of gastrointestinal problems in patients with ASD diagnosis. His interest is in this unique patient population, and it began in 2001, and during the ensuing 17 years that he has treated over 1,900 children from across the globe. His research lies in the characterization of the unique cellular, molecular, and clinical features of inflammatory disease in this population, and his findings appear in numerous peer-reviewed journals. Dr. Krigsman is board certified in pediatric gastroenterology, hepatology, and nutrition. He received his bachelor's degree and MD at Johns Hopkins University, Maryland, and completed his residency at State University of New York, Brooklyn. He received his fellowship in pediatric gastroenterology at Mount Sinai Medical Center, New York, and is a member of the North American Society for Pediatric Gastroenterology, Hepatology, and Nutrition. His greatest satisfaction, however, derives from the clinical care that he provides his patients and in the improved quality of life that results from diagnosing and treating gastrointestinal disease in this population. He maintains offices in both Northern California and Austin, Texas. Welcome, Dr. Krigsman. I'll now stop my share so you can continue.
So I can control this. Okay, perfect. Okay. Okay, good morning, everybody, or good afternoon, or good evening, depending on where you are in the world. So we have a very interesting topic for today. It's really, when you speak about autism in general, such a wide topic. There are so many. There's the primary disease, there's the comorbidities, which by the way is really reversed because we're used to thinking of the primary disease as the neurological disease, the behavioral abnormalities. In reality, I and those who I work with are under the strong impression that the neurologic manifestations are just one of many downstream effects of an upstream immunologic abnormality, that the GI tract and that in many cases the joints and the skin and often the thyroid gland, those are all organs that are being damaged as a consequence of the immunologic abnormality. So the point being that it seems to be a very, very complex disease, the most complex that I'm aware of. And we know, as you know, so little about it. But the nice thing about the gastrointestinal disease is that it's an easy organ to get to and to biopsy and to study. And from that, we're able to understand a large piece of what's happening. So because of the, as many of you know, and as the introduction had said, I've spent many years trying to understand this unique inflammation that occurs in the gastrointestinal tract of children. And I want to begin this lecture first by just briefly going through what many of you may have heard before, but interestingly, most parents, even who hear it, for some reason don't think that the GI disease and the things that I say apply to their child. And I find it very interesting. So I guess the first thing I would say is that everything I say today, assume that it does apply to your child. And then you can think through afterwards, and when you watch the video, and you could think how, and I'm going to speak about different things that we can do. And then the most interesting thing of all, with a big shout out to the Brain Foundation, is the results of our most recent study, which is being submitted for publication, showing
Dr.
that treating.
Krigsman, one moment. Can you please share your slides and also turn on your camera?
I'm sharing the screen. Okay, so the video is now on, right?
Yes. We need you to
Okay.
share your screen. At the bottom, if you click on the green button to share.
Yeah, I'm sharing. Oh, I see, because I moved it. All right. Okay, can you see the screen now?
Yes.
Can you see me now?
Yes.
Okay, perfect. Okay. Okay, but everything I've said so far, everyone has heard?
Yes.
Okay. All right. So the main thing is that everything I say, everyone should assume from a gastrointestinal standpoint does apply to their children, even if the photographs that you might see or the things you might hear in your mind, even if you might think that these are extreme cases, it's not the case. It can get to be extreme if many years pass and nothing is done about it. But even at the very beginning of GI symptoms and brain involvement, there is gastrointestinal inflammation that is going on. And what the role of that is, again, we're not clear. So again, with the big shout out again to the Brain Foundation, we have submitted the results of a treatment study demonstrating that when you have ASD and you have gastrointestinal inflammation, that's proven on endoscopy and biopsy, and you treat the gastrointestinal inflammation with the standard way of treating an inflammatory bowel disease. Not only do you improve the GI symptoms, which we're going to go through pretty quickly, but you also improve the cognition and the behaviors of these children, as shown on standardized, validated ASD questionnaires, many of which you filled out, like the ABC, like the SRS, like the Vineland. And also, I want to thank my co-researcher Steve Walker for the laboratory help, which has been really invaluable throughout all these years. So the first thing we're going to do is we're going to speak about briefly. I'm going to mention ASD-associated enterocolitis. And that means that you have an intestinal inflammation of the kind I was speaking about, which occurs to some degree in the majority of children who have autism. And we call it ASD associated because the type of inflammation that these children have is different than other inflammatory bowel diseases like Crohn's disease and ulcerative colitis. It's very similar. There's a lot of overlap on a cellular and a molecular level. And we've published all of that in the past. So there is overlap, but there's also important differences that make it unique to ASD. And of course, in meaning it's only, in other words, you don't find that bowel inflammation in other developmental disorders. You don't find it in Down syndrome. You don't find it in in patients who have neonatal asphyxia. You don't find it in stroke patients, children. You only find it, this bowel inflammation in children who have the neurologic symptoms that allow us to call them, to label them as having ASD. And that immediately means, of course, that the bowel inflammation is something to do with their being autistic. And that, of course, is a fascinating concept. Okay, so with children who have ASD and to have this bowel inflammation, this is certainly true towards the beginning of the development of their GI symptoms and GI disease, and it's certainly true as the disease progresses. What are their symptoms? Diarrhea. Doesn't have to be watery diarrhea. It could just be loose, unformed stool, constipation, which is usually meaning, in this case, trying to pass a bowel movement, but being unable to. And the stool is not overly hard. So there seems to be a motility problem in these children where they spend a good deal of effort and time trying to get the stool out, and it is not able to. Abdominal pain, which we'll speak more about in the next slides. Failure to thrive, growth failure, usually takes the form of a problem gaining weight. It usually does not take the form of a problem growing taller, although when advanced, it begins to impact your linear growth and your height as well. Of course, the extreme of that will be weight loss. There's vomiting, food refusal, times a day or two or three where these kids won't eat anything at all or very, very little. Abnormal stools, meaning the odor is very bad. There's malabsorbed food in the stool. The color is off. It's like yellow beige. And food intolerances. Those are the signs that as a parent or as a caretaker should set you off that in the setting of autism that there may very well be an associated inflammatory bowel disease. It doesn't mean you have inflammation of the intestine. It doesn't mean you have ASD-enterocolitis that's similar to Crohn's and ulcerative colitis, but it does mean that you have something wrong with your GI tract. When you have this bowel inflammation, what's interesting is that we've learned over the years, and this is brought out in our current study funded by the Brain Foundation, that there are certain behaviors, and I call them behaviors. We've historically thought of them as autistic behaviors, but there are certain behaviors that seem to be very prominent when children are having GI difficulties, meaning the behavior doesn't mean that you definitely are having a GI problem, but there's certain behaviors that more than others are manifestations of gastrointestinal disease. And when you see those behaviors, that also is a red flag. For example, abdominal posturing, where these kids try, as many of you know, to put pressure on their belly. They often try and place the parent's hand on their stomach. They lift up their shirt to show the parents their abdomen. They bang and tap on their chest, arching their back. Easy fatigue, poor sleep problems, falling asleep problems, staying asleep, humping, pressing their abdomen or their pelvis into a mattress, a pillow, a blanket. A lot of them assume a Muslim prayer sleeping position. Rumination, meaning food coming up into your mouth and then swallowing it, is also a common thing that we see. And again, the psychologists and the psychiatrists are very quick, perhaps too quick, to attribute these behaviors to autism. But we know, and we've shown in this most recent study, that more often than not, these particular behaviors are manifestations of underlying intestinal inflammation. And when you treat it, and how do you know that it's treated? When you treat it and the GI symptoms go away, the stools normalize, the abdominal distension normalizes, the growth resumes, then these behaviors, many of these behaviors, if not all of them in some patients, markedly improve or completely resolve. And then you know in retrospect that these, in fact, were not autistic behaviors, but rather manifestations of an inflammatory bowel disease. And also, I should say, these behaviors are not unique to bowel disease. Of course, it's possible to have head pain and also have aggression and self-injury. So you really don't know from the behavior itself what the source is. But as I said, these are the behaviors that we see most often from all the various behaviors that these kids do. These are the ones that most often end up being manifestations of an underlying intestinal inflammation, extreme temper tantrums. Many of you have, I'm sure, experienced that with your children. A lot of the kids who can talk, and even those who can't, will have three words: "My tummy hurts," which to me is always it's always so interesting that you have someone who doesn't talk, either because they can't or they won't or it's difficult or for whatever, but they'll say three words: "My tummy hurts," and there seems to be confusion amongst the people that take care of them. Um, if that means they have a stomach ache or not. Well, of course it does. You know, that this is the only thing that they say. The kids that spell, the advent of the whole RPM and S2C and spellers and that whole thing where kids can now communicate, many kids. Um, and they've taught me a lot where the ones who get really good at spelling will explain to me exactly what they feel and the things they'll say about their abdominal pain just blows you away, just like the things they say about other things, politics or history or anything else. Pinching their neck, sticking their finger down their throat. These are all behaviors. This slide we're going to go through very quickly because as a parent, you have a child, your child is manifesting, they're exhibiting these behaviors, either these behaviors or those abnormal stools. And your first question is there a disease here that I need to address, or is this just some kind of transient infection or toddler's diarrhea? And it's a question that parents with children who don't have ASD will have also. So there are standard workups, both in the field of general pediatrics and also in the field of pediatric gastroenterology. What do you do when confronted with these symptoms and these signs? And below is just a list of a variety of things, a variety of diagnoses that these behaviors or stools could mean. And it's only a small sampling. There are many other pathologies that it could be as well, or it could be no pathology at all. It could be just a passing bad food that you ate and you're sick for a couple of days. As a parent, when should you start getting nervous about abdominal pain? Because if you look at your child and as a parent, either the child is saying my tummy hurts and you know they're in pain, or they're clearly in pain, they have the face of somebody in pain, or you have a strong suspicion that they're in pain, and trust your intuition. More often than not, when a parent thinks the child is in pain, even if they're not doing the things that you and I would do if we're in pain, the parents and the mother in particular is usually right. What are the red flags? What are the things that you should insist need to be investigated and evaluated thoroughly? Involuntary weight loss, a deceleration of height, blood in the stool, vomiting, which is not, which is more than just an episode here or there, but rather regular vomiting, protracted vomiting, vomiting that goes on for hours, um, chronic diarrhea, diarrhea that just doesn't go away, unexplained fevers that are associated with the pain. If there's a strong family history of inflammatory bowel disease, of Crohn's disease, or ulcerative colitis, and this child has pain, then that is also a red flag that needs to be, you need to be, tests have to be done, and there are non-invasive tests, and we'll get through, we'll go through them that would need to be done to see if there is pathology in this child, or if we can just say, let's wait it out, or if we could be sure that it really is not pathologic. Constipation is probably the most common GI symptom. And this is just a quick slide. Hopefully you'll be able to get a copy. I don't want to spend time on it, but this is the pretty much the full gamut of what can cause constipation in children. Many of them are quite unusual, whereas autism is quite common. And constipation and autism is quite common also. So finding many of these diagnoses in our kids, it would be unusual but not impossible. But they always have to be kept in mind, and many of them need to be part of routine workups of chronic constipation. And again, this is what you should expect. This is the kind of examination that you should expect your doctor to be doing when you come in with a child who's constipated, ASD or not, doesn't make a difference. But this is really just more for your general knowledge, what as a parent you should expect to be done. But what shouldn't happen is you bring in your ASD child, they're in pain, whether it's obvious or not, but you suspect that they're in pain. There's blood, there's constipation, there's distension, there's poor growth. What you know should not happen is reassurance, a let's wait and see attitude. That should never happen. At the very least, the workup that I'm showing you now should be done at least in part. Okay, this is the general approach that we have to children with chronic diarrhea. Again, we're not going to spend a lot of time on this slide because this is just something for you to know would need to be done. These are the more common causes of diarrhea. And if that's what your child is having, this is what you should expect to be part of the workup, but not being dismissed or being downplayed or being necessarily being given reassurance that may be inappropriate. So when a patient comes to me with ASD and with any of those abnormal types of stools or abnormal types of behaviors, even both. And I say or behaviors because sometimes the stools are perfectly normal. And there is underlying GI pathology, and the only sign, the only symptom, the only manifestation of that GI pathology is a behavior like aggression or self-injury. So unexplained aggression or unexplained extremes of behavior in a child with ASD, you must think of the possibility of underlying GI disease, and I would include this workup. Here you'll see a list of various blood tests, various stool tests, just a simple urinalysis, and also imaging studies because constipation is so common. Even in kids who are having a bowel movement once a day and the bowel movement seems to be normal in volume and the stool looks normal, it's part of the autism package to have fecal loading. So even if it doesn't sound like there is a problem with constipation or stool backing up, that has to be proven by imaging. And normally all you need is the abdominal x-ray. You would not normally need any kind of barium studies like an upper GI series. Let's say you do this workup, okay, and with this workup, you cover the vast majority of the diagnoses you saw in the GI diagnosis you saw on the previous slide. Let's say you do that workup and everything is negative. Okay, so the answer at that point is not everything is okay with your child. Your child's crying, your child's in pain, your child's having distension. There's a problem with growth. There could be some microscopic blood in the stool. There could be unexplained aggression, extremes of behavior. Something is wrong. Just because a series of tests don't find it doesn't mean nothing is wrong. We can only test for what we know is there. Um, you can only test to look for something that something specific. If we don't know, or if we're not thinking of it, we're not going to test for it, and we're not going to be able to make the diagnosis. But what can you do before doing anything drastic or invasive? What can you try? Um, so number one, what I found over my years of experience is that you do a trial of dietary restriction. If taking out gluten, um, not so much lactose. I have lactose written over there. I really think I'm going to delete that from my upcoming slides. Um, in my experience, it's the food intolerances that these children have that give them GI symptoms are more protein-based intolerances. This is just what I found over the years, more so than a lactose intolerance, which is of course, a carbohydrate. Um, any foods that your child has that he or she is IgE positive to. There are those who strongly believe that if you're IgG positive to a food, that may also be an indication of food sensitivity. In my mind, although it's possible, I'm not convinced of that. But certainly, if you wanted to try that for a period of time, there's nothing wrong with that as long as the child continues to get enough calories. You could do a trial of an acid blocker, but if the underlying abnormality is somehow related to having excess acid or even normal amounts of acid in the GI tract. So you can give a 2 to 4 week trial of blocking the acid and seeing what happens. If it is an acid related disorder, the symptoms will go away. If the child has severe constipation, you could do a trial with the laxative for approximately 4 weeks. And this is a variety of laxatives that I've listed over here, and you can try any or all of them. But again, for a period of time, it's important. You have to draw a line in the sand. What a lot of parents do is because they're afraid of the next step. They're afraid that maybe there really something is wrong, something pathologic in the intestine, and they tend to get stuck in cycles of food restrictions and re-challenging, and then different types of laxatives and different protocols and combinations, and you get stuck in that, um, in that wheel for months and months, and sometimes for years and years. Don't let that happen. If you're going to if your child has these problems and you want to do a trial of empiric therapy, empiric means that the word empiric means that you don't have a diagnosis, but you strongly suspect that it might be due to these, and there's no harm done by doing a brief trial. There is harm done by doing a prolonged trial. The major harm is that you're not going to find the real culprit for as long as you're stuck in this cycle. And also a trial of antimicrobials or probiotics, trial of digestive enzymes, again, with drawing a line in the sand. We'll do it for 4 weeks, we'll do it for 6 weeks, do it for 8 weeks, but not longer than that. Otherwise, again, you will be stuck in that for a while. Some empiric treatments that should not be tried, meaning if you don't have a strong idea or a strong belief of what the diagnosis is going to be, what should you not do? Well, what you should not do is say, well, maybe he has inflammatory bowel disease. Let's try giving him a month of steroids or a month of immunomodulators or a month of anti-inflammatories for the GI tract. Um, that I would not do. If you're a millionaire, you might want to try giving empiric elemental formulas. They're very, very expensive. They're also very, very hard to give because they don't taste good, and kids often refuse to cooperate in taking them. But there's no harm done if you would try an elemental formula for a prolonged period of time. The nice thing of having a confirmed diagnosis is that once you have that diagnosis, then the formulas by law our insurance companies have to pay for them. Okay, so what usually happens though, okay, in the setting of autism and the kids who end up coming to me, and that may be just a certain bias on my practice. It may be, in fact, what autism is. But in general, if when I see a patient, if the non-invasive workup described above does not reveal a diagnosis, meaning the tests are all negative, then in that case, an endoscopy or colonoscopy, usually in a capsule endoscopy, the pill cam are necessary. There are, which is the case with many diseases. Many diseases, like other inflammatory bowel diseases, Crohn's, ulcerative colitis, those are all made on a biopsy, so we can look at the tissue under the microscope. We can classify the disease, and then we know which medication is best to give. And not just, and it's more than just knowing whether the disease is present or absent. It's also knowing where the disease is. Is it the most of the GI tract? Is it part of the GI tract? Is it just a small bowel? There's a small bowel and the colon, and or does it involve the esophagus? Does it involve the stomach? These are all things that you might have an idea if the patient was communicative to you. You may have an idea in advance what to expect to find, but with ASD and these symptoms, it's always a crapshoot. You never know what you're going to find. It's like Forrest Gump eating a box of chocolate, right? You never know what you're going to find. Um, the vast majority of kids with ASD and these chronic GI symptoms that we discussed who do undergo endoscopy and colonoscopy, they are found to have an autism-associated enterocolitis. Often there's something else going on as well, like reflux or something else. But those secondary diagnoses are usually a consequence. Usually a consequence of the underlying inflammatory bowel disease. Um, and that's an important point because with the GI tract, as with many other organs, once you have one physiologic process that's not functioning normally, it tends to have a cascade, and it leads to a second, and then to a third, and then to a fourth. So for example, a lot of parents ask me about SIBO, about small intestinal bacterial overgrowth. And even though there's been no study looking for that and showing that it occurs in these children, I do believe that many of them have it. But even that, SIBO would be the secondary diagnosis. You get SIBO, you would get an overgrowth of bacteria when there's stasis, when there's poor movement or no movement of stool and GI tract. That's when the bacteria has a chance to overgrow. So by focusing on what is perhaps a secondary diagnosis and treating it, you're only going to come back to the same problem after you've treated it, unless you've treated an underlying problem. How does one diagnose endoscopy? I'm sorry, has one diagnosed autism-associated enterocolitis? So you can see the various abnormalities of the colon. For those of you who are familiar at all with gastroenterology, you know that these are both examples of a colon that is abnormal, this colon being more abnormal than this. It's a question of coloring, it's a question of vascularity, it's a question of edema, how smooth and non-smooth it is. One of the hallmarks of this disease, of autism in general, being an immunologic disease, lymph nodes that are present in various areas of the body, not just the gastrointestinal tract, are often enlarged. The lymph nodes of the gastrointestinal tract tend to be markedly enlarged, and that's what drew the attention 25 years ago, the first group of researchers who really became interested in the gastrointestinal disease and autism were pictures like this of the ileum. There's this huge lymph node here, and there are many others as well. And the lymph nodes themselves are not the disease. A huge lymph node is just an indication that the immune system is having an inappropriate, exuberant response to something that it thinks doesn't belong there. With the autoimmune diseases, we don't know what that something is. As far as we can tell, there is no organism, there is no foreign body, there should be nothing triggering the immune system, but something is triggering it, and it doesn't turn off. And it's triggered for months and months and years. And during that time, the lymph nodes get bigger and bigger, and that's what we see in the GI tract. So that's not the actual disease. This is not inflammation. This is an indicate. When I see this, I know there's going to be inflammation somewhere in the intestine, but this itself is not inflammation. These are examples. Colon, this is an area of a patchy area of inflammation. This is the ileum, which is the end of the small bowel, where neutrophils are invading the crypt of the ileum, which is it's a mild ileitis. One of the interesting differences between the autoimmune autism-associated enterocolitis and Crohn's and ulcerative colitis is that the intensity of the inflammation, meaning the number of cells, the amount of damage being done to the tissue, is worse in Crohn's disease and in ulcerative colitis than it is in autism. However, on the flip side, this milder degree of intestinal inflammation in autism is associated with a devastating neurologic deficiency. So when I look at these kinds of these kids, and when parents always ask me, how bad is it? And my answer is not based upon the intensity of the inflammation or the damage done to the gastrointestinal tract. My answer is always, it's as bad as their neurologic impairment. That's really how I grade the inflammation of the intestine. Whether that turns out to be a proper grading over the coming years, more will be learned. But that really is how I see it at this point. And then there are the kids who are older, the older teenagers, or the kids who were in their 20s, who have been untreated for so many years, who their disease has now progressed really to look indistinguishable from actual Crohn's disease. So over there, the question is really moot. But the kid who's 4 or 5 years old, who would have biopsies that look like this, much less intense. I do think that to say that, well, the tissue damage is not so terrible, so let's give a mild medication, I think it's a mistake. I think that you cannot grade the intensity of the disease, of the bowel disease, based on just what you're seeing in the intestine. As mentioned before, okay, so once we get our biopsy, we show our inflammation. What's my diagnosis? Okay, so I call it ASD-associated inflammatory bowel disease. Why? Because we have strong clinical, cellular, molecular evidence. It's all published, in multiple times, and it's in multiple organs. So we found it in the stomach, we found it in the esophagus, we find it in the small bowel, we found it in the colon. That it has so many unique features. On the other hand, so many similar features to Crohn's and ulcerative colitis, but we do give it a different name. Fortunately, because it's an inflammatory bowel disease with significant overlap with Crohn's disease in particular, it seems very logical to treat it, for lack of any other option, to treat it the same way that you would treat Crohn's disease. And the way we treat Crohn's disease, because Crohn's disease also is an autoimmune immunologic abnormality, and the way we treat it ultimately is by subduing this abnormal immune response. And there are many ways that we can do that, and different doctors like different drugs and like different protocols. And really today, in the year 2024, there are so many medications now that are available, especially for older kids. You go back 25 years or so, we had very few choices. So those of you who are parents of young children, as devastating as ASD and the accompanying bowel disease is, think of yourselves, think of the silver lining in that there's so much more that we could do as far as medications, and we understand it so much better as well. Thanks to organizations like the Brain Foundation that funds researchers that are interested in immediate application of various therapies for this. What's really interesting and what we didn't expect is that when we treat the inflammatory bowel disease of autism, I fully expected that they would respond from a gastrointestinal standpoint. I fully expected that their diarrhea, that their pain, that their distension, that their growth would improve. What I did not expect was that their cognition, their actual ability to think, their receptive language, their understanding, their ability to predict if you do A, then B will happen. And those of you, of course, who have children that are affected know exactly what I'm talking about. Awareness of what's going on, knowing why people are where they are and what they're doing, just an interaction with the world. I didn't expect that would change by treating a bowel inflammation. But to our great surprise, we found that when we treated the bowel disease to the point where we saw marked improvement or complete resolution of their presenting GI symptoms, what we found was that their cognition and their behaviors improved. And that, of course, led me to wonder, maybe some of these behaviors are not really autism. Maybe some behaviors like unexplained aggression, self-injury, and many other behaviors also, even stimming, some types of stimming. Are they not, in effect, part of autistic pathology, brain pathology, but maybe they maybe they're actually manifestations of a GI disease, a neurologic manifestation. It's part of the gut-brain axis that you've read about. I didn't expect to encounter that, but that's exactly what we did encounter. Some kids cognitively and behaviorally improved markedly, some kids minimally, and other kids everywhere in between. We did a series of, retrospective chart examinations looking to find any clues whether if you can predict who would respond cognitively better than another patient, and we didn't find any. We went back to the biopsies, and everything seems to be the same as far as we could tell. So clearly, we have not found what it is that will help the brain when you treat the GI tract. I have some theories, some ideas, which maybe are not quite ready for prime time and public announcements. Maybe that'll be one of our future studies. That remains to be seen. But as I wrote in the last bullet point, they have now been scientifically investigated with our current study. And this is the current treatment study that I want to speak about now as well. And I may take a bit more time if that's okay, so we can go through the study. We're not going to go through the study in detail because the details, you can get bogged down in them, and it could be another hour with all of you sitting here. But certainly after the lecture, I'm happy to be able to answer any questions. So the research question is, does treating ASD with the protocol that I chose to use on patients, because I found it to work the best in the ASD population, is once they're diagnosed with this inflammatory bowel disease in the setting of autism, I have found that the best drug by far for their GI tract and their brain are corticosteroids for a short period of time, followed by a trial of non-steroid anti-inflammatories, the kind that we used a lot of 20 years ago. And then if the patient showed me that, the non-steroid anti-inflammatory wasn't quite holding them, meaning that we started seeing the slow return of their GI symptoms after withdrawal of the initial corticosteroids, on those patients, we would use, I've adopted the protocol of at that point introducing medications that are used now as standard of care in Crohn's disease, really from the get-go. Immunomodulators, meaning drugs that modulate the immune response. They regulate the production of immune cells, primarily the bone marrow. There's a newer class of agents, it's almost 30 years old. Or they are, but it is 30 years old, it's more than 30 years old. They're called biologics. And treating them with this protocol, and again, these are all medications that are commonly used in IBD. Perhaps the order or the dosage may be a bit different, but these are all routine drugs that we always use in IBD. Does it help their GI symptoms? Does it help their cognition and behavior? The study design is that, well, if you want to know if that medication protocol for their GI disease, if you want to know if it helps their GI disease, you have to have, the only way to know, aside from scoping them every month, which is not an option, would be to have the parents answer a questionnaire. And the problem that you immediately run into, and this applies to really almost every paper that you're going to read that deals with autism and treating GI disease with other types of GI interventions, is that the questionnaires, the GI questionnaires that we use in academic gastroenterology to determine if a drug is helping someone, those questionnaires rely heavily on what the patient says they feel. Are you feeling better? How much better? Where is the pain? How intense is the pain, etc. Of course, our patients can't answer that. The objective indicators of disease, is there bleeding? Is there weight loss? Those things, of course, are easy. Are markers of inflammation? Does the ESR get better? Does the CRP get better? Those, of course, you can follow. But the way the patient feels, which is the most important, of course, you don't know. So we decided to make up our own questionnaire and to base the questionnaire upon the behaviors that we were constantly hearing patients say, like the unexplained aggression, extremes of aggression, extreme tantrums, the posturing, the pressing their belly, their abdominal distension, things that we would hear over and over and over again in conjunction with abnormal stools, which you can see, anybody can see. So we decided to take those behavior. Well, again, the distension wouldn't be a behavior, but a lot of the behaviors, even stimming, hitting your chest, sticking your finger down your throat, is a whole slew of behaviors that we would hear. And we put those into the questionnaire. And we asked them to answer this question, the same questionnaire at baseline, and then every week thereafter online for a year to see what their response was. Now, answering a questionnaire once a week for a year it's a big ask. It's a big ask. And I really sincerely and wholeheartedly thank all those parents who did that. And there were many. And the reason I wanted the GI questions to be done every week is because throughout that first year, there's a constant change. The protocol calls for a constant change in medications, and I wanted to see what the response would be to the protocol, the typical protocol that I had found clinically to work the best. What actually does happen to the patients, and how often, and to which patients. So that's the GI questionnaire. We had, again, the GI questionnaire was one about the bowel movements themselves. I call them the stool descriptors, the color, the shape, the frequency, the odor, the maldigested food. Questions about that, and also questions about externalizing GI behaviors, meaning like the aggression, sticking your finger in your throat. So those were the GI questionnaires. And then, of course, we also had the standard validated ASD questionnaires, and we chose the ABC, the SRS, and the Vineland, which undoubtedly you know all about, because if you're on this webinar, you've probably filled out more than your fair share of those questionnaires. Okay, the primary outcome measures, of course, as we said, is improvement in the stool descriptors, improvement in what we strongly felt to be behaviors that were most likely to be GI related, and of course, core deficits of ASD. We ended up we started right when COVID began. The timing couldn't have been worse. So it should have been a 3-year study. We estimated that, to get enough patients to have the study powered enough. We would need about 25 patients, and also the because we're asking a lot of patients. We're asking to fill out these questionnaires, and it's all these parents, as you know, as all of you are overwhelmed. You're overwhelmed with just your day-to-day life and your schedules. So the percentage of patients that we expected to be able to go through the full year and answer the question wasn't very high. So we anticipated a 3-year study. The first year was COVID, which made it immediately into a 4-year study. But we did end up having 25 patients. We had, if you looked at all the bowel movement charts, right, to the stool descriptors, which is the one that most interested me, we have over 1,000 bowel movement charts. So many patients, they started for the 3 months or 6 months, and then they dropped out, but we still had their data for a period of time as a source of information. And of course, the p-value of statistical significance is less than 0.05. Is what we incorporated. We had 17 questions of total on the bowel movement chart. The breakdown of the types of questions are on the list. We're not going to read them down. And these are the results. Very, very interesting. I don't know how many of you are familiar with reading these kinds of graphs, but basically, this is on the horizontal axis is time, and the scores, which we scored it. We created our own scoring system based upon the questionnaire, the GI questionnaire, and what we found was that the stooling behaviors, meaning the behaviors that the kids did while they were having their bowel movements. A lot of kids would squirm on the seat, would squat on the toilet seat, would grunt, would do all kinds of interesting things while they're having their bowel movement. And in those patients, we found that they came in symptomatic, and they, after the first 12 weeks, 10 to 12, or it was 8 to 10 weeks of treatment, which was still while they were on corticosteroids, that's when we saw the drop in the degree of difficulties they were having around passage of stool. And again, when the paper does come out, there'll be a lengthy description about what behaviors there were and what exactly what improvements we saw. But for the purposes of this lecture, it's the overall, you can think of it really as the overall difficulty that so many of these kids have in passing a stool, whether it's straining to pass it or even getting it out. I'm sure many of you in listening have had the experience with your children of the child walks to the bathroom, sits down, tries to pass stool, nothing happens. They get up, they walk around again, they go back to the bathroom, and they try and pass stool again. And bowel movements become a major part of the day until the stool comes out. And then when the stool comes out, they seem to feel better. I'm sure many of you can appreciate that scenario. So that's what we're talking about, stooling behaviors, and we saw a significant improvement. The stars up on top, that's the p-value. So the more stars you'll see, the more statistically significant it was. And in in the case of stooling behaviors, it was 0.01. As far as the characteristics of the stool, the odor, the form, the undigested food, the color, the frequency, there we saw an even greater improvement and an even greater response to the initial course of corticosteroids. So what we're seeing over here is that the corticosteroids are inducing a remission. And then when we come off the corticosteroids, the remission is being maintained with a variety of other drugs. So some of these patients had their remission maintained on a non-steroidal anti-inflammatory. Some patients had their remission maintained on immunomodulators. Some of them had on biologics. And it just depended, again, there was no deviation from how I would normally treat this patient. But after the 25 patients were done, we took a look back and we saw that in whatever road this patient went down, the initial remission was obtained with steroids and was sustained with some other form of modulating the immune system, form or forms. Some patients needed 2 drugs. Some patients needed 3 drugs, and that's true. That's the case with Crohn's disease and ulcerative colitis and other IBDs as well. In terms of frequency of events, and again, when you see the questionnaire, you'll appreciate what that means. And then when you take the composite score, when you look at all the GI questions together as one score, you see that there's a significant, actually here you have 3 stars. So it's highly, highly significant improvement. And many of you as parents have told me over the years that you can deal with your child's ASD. You can deal with that. But what the parents say is that they cannot deal psychologically, emotionally with the child's being in pain, not being able to pass stool, they're being sickly, they're not growing. That was much, much harder to deal with in general. So seeing an improvement just in the GI tract and in the GI disease, and not just an improvement, but a major improvement, was a major accomplishment that confirmed what we had been seeing for many years. The nice thing about the study also is that it was done after me treating so many of these kids over decades. So even though we were blinded, in other words, to extent the parents were filling out the questionnaires and we didn't know what they were going to fill out, but I knew what to expect based upon my previous experience. But it was nice to see. That my experience actually on paper and in graphic form. How about the externalizing GI behaviors? Okay, so never mind what the stool looked like, but how about the behaviors that I had always felt were manifestations of underlying inflammatory bowel disease? How did that pan out? Were my guesses right? Were my guesses wrong? Were some right and some wrong? So if we broke down the questionnaire, which again you will see when the paper is published, there was we were looking at behaviors, the extremes of behaviors, behavioral signs, or abdominal pain. And over there, we saw the same thing, the initial improvement on corticosteroids and a sustained remission with a variety of non-steroidal medications, extremes of behaviors. What's an example of an extreme of behavior? Throwing light bulbs and smashing things in the house, kicking walls and kicking and breaking sheetrock. Many of you have experience with this as well, and these are things that we looked at. And again, on corticosteroids, we got the remission, and we were able to maintain it with again a variety of other drugs. And I must say that of all the other drugs that maintained remission, the biologics were by far the best, meaning the drugs like you've heard of, like Humira or Stelara, and now there are so many others on the market. Those turned out to be a godsend for these kids, both from a GI standpoint and also from a cognitive and behavioral standpoint. Abdominal pain, same thing. The initially huge improvement with the induction corticosteroids and a sustained remission. And then the composite scores of all the GI manifestations that we've discussed taken together. What did we see? We saw 3 stars. So we saw a huge improvement compared to baseline. And the vast majority of the kids really had complete resolution of their GI symptoms. The most pesky symptom has always been constipation. And we have a protocol how to work with that as well, but there still are patients who just their motility is so bad, and we struggle with them. And I know for a fact that there are 2 of them on this webinar, and all I can say is that we're still trying. I'm always thinking and looking to see what pharma's putting out that we might be able to apply to our kids also. Okay, so how about cognition and behavior? So when it comes to the ABC, to the composite score, you see again at the very beginning, you see a worse score. They have more intense ASD traits. And then as their GI issues resolve, concurrent, I'm careful not to say as a consequence of, I don't know that, but certainly concurrent with the improvement in their GI, in their variety of GI symptoms, there's also an improvement in their composite ABC scores. How about the social responsiveness scale, the SRS? The composite scores again. And in the paper, in our paper, we're going to break it down further into the various subsections. But the subsections for the same thing as the composite score. It turned out to be the same. That you saw improvement concurrent with the improvement in the GI symptoms. For the Vineland, for the composite scores, remember that for the Vineland, the lower composite Vineland scores are associated with a greater level of dysfunction. So we saw over time there was actually a highly, it may not look very significant to you on this, but the number of data points and the degree of improvement made it a 3 stars. So highly significantly statistically significant. We're not talking about a cure. We're not talking about a cure of autism. These children had ASD at the beginning of the study and they had ASD at the end of the study. But in my mind, the huge advantage of being able to treat the ASD and improve their cognition is that once you've treated their medical problem and their brain is not foggy anymore, and they'll tell you, they'll spell this or tell this to you, my brain isn't foggy, then they can show you what they can do. And those of you who are involved in spellers who've seen firsthand what so many of these kids are capable of, and for the most part, they weren't capable of that while they had active inflammation, systemic inflammation of the GI tract and of the brain. You treat that, then you give them a chance to show what they can do. And as of right now, until we find a way to approach the core immunologic abnormality and cure it, Until then, my goal is to make these kids as healthy and high functioning as possible so that they can be as productive as possible. And for the violent, for the maladaptive behavior, and the individual domain scores on the Vineland are associated with higher level of a domain function. Okay, and then we have the Vineland maladaptive the externalizing behavior. So we see lower levels, meaning higher functioning in the individual domains. And we see that in both the externalizing behaviors and internalizing behaviors. So these last two slides in summary, from a GI standpoint, you have the bowel movements themselves and how they're described, all improving through the study significantly as a whole, as a composite. And the behaviors that turned out that for the most part, we were right. That when you had unexplained aggression, at least when that's accompanied by an overt GI symptom, extremes of behavior, sticking a finger in your throat, so many of the other behaviors that psychologists would often say is and you've heard it yourself, I'm sure, from many therapists you've been to, it's just part of their autism. We know that that's not the case now. So many of those behaviors are actual manifestations of GI disease, and which means that if you see that, you need to find someone. Who'll take that seriously, who knows this information, and is going to do the workup that we described at the very beginning. First, non-invasive workup, and if nothing is found, then go in there and see what you do find. And if you do find it, you treat it. And then, of course, to summarize the ASD part, the ASD improvement when we treat the GI tract disease, the inflammatory bowel disease of the GI tract in particular. You see again the same thing, the improvement on the ABC. You see the improvement in the SRS, and you see the improvement both in the domains of the Vineland and also on the composite score of the Vineland. Takeaway is basically what I've been repeating over this entire lecture. And I think I'll open it up now to those of you who have questions that you want to ask.
Dr. Krigsman, if you can please unshare your slides. I wanted to take 5 minutes to talk about the Brain Foundation, and then we'll open up to questions.
Okay.
Thank you so much for that presentation. Again, this was one of the first studies that we started funding. And it's so amazing to see the results, and also looking forward to the publication. This is really amazing. And to all of you who support the Brain Foundation and fund our studies and help us by volunteering, thank you all so much. And thank you for those who participated in the studies as well. So I'm going to quickly overview. I won't take much time, but I wanted to quickly overview some of the grants that we have provided this year, because it's these grants that eventually result in these kinds of findings and really helps us move the needle as far as treatments go. So this year we have funded, sorry, let me just, okay. So this year we have been funding every year about 10 studies and over 1.2 million a year. And we focus on basic research as well as clinical studies and treatment studies. So the projects funded for 2023, 2025, we received an overwhelming 170 applications, and we had to go through peer review and selected the following areas of study: biomarkers, treatment trials, immune abnormalities, epilepsy, speech, motor behavior, neuroinflammation, and so on. In biomarkers, this is an important aspect because this will help studies and getting to drugs much faster. So this biomarker study is University of Texas Southwestern Medical Center, and we will be studying a blood biomarker, which hopefully will turn out eventually to be a method to track treatment response. There's also a potential biomarker for NDD and ASD diagnosis using autoantibodies and cytokine biomarker discovery. This is Dr. Shannon Rose at Arkansas Children's Research Institute. Other treatment trials that we are looking at are oxytocin, cobinamide, edaveron, bizafibrate, and metformin. Oxytocin signaling, this study is from University of California, Berkeley, where they are developing near-infrared oxytocin nanosensors to image oxytocin at synaptic levels by imaging and measuring oxytocin signaling differences in the brain. There's also this study, which is an inflammasome activity in autism spectrum disorder by Dr. Richard Deeth, who I believe is present today. This will be studying the use of cobinamides, a vitamin B12 precursor, as a novel therapeutic target for autism. We will also be looking at interplay between genes and environmental factors by Dr. Adrian Ashragi. And this will be testing the use of edaveron, a readily available FDA-approved drug, repurposed as a potential new treatment modality. We will also be looking at identifying neuronal ensemble activity as a biomarker. This is Dr. Maltesh Kambali. This will be looking at identifying biomarkers for blood-brain barrier dysfunction and looking at therapeutic approaches like FDA-approved drugs, bizafibrate, and so on. Immune abnormalities, we are looking at a study with Dr. Paul Ashwood, who has been studying these areas for some time now, looking at the relationship between innate immune activation and ASD and GI comorbid patients. And this may lead to development of simple diagnostic tests to identify patient-specific factors to control immune response, specific to ASD associated with the IBD, which is very related to the talk that we had today. Apart from this, we are also funding one study in the neural assessment of speech comprehension in non-speaking autism. This is a Stanford study by Dr. Laura Williams. And this will be the first test that will advance understanding of how non-speaking individuals process language, receptive language ability, and which can inform development of tailored communication approaches. This is also another study of spelled communication and the utility of that in autism. So this study will be investigating the efficacy of spelled communication and also to determine if extensive use of spelled communication is warranted and whether it improves communication and development and quality of life. It's the first ever retrospective and prospective trial of spelled communication. This one is an emotion perception training study by University of California, Berkeley, Dr. Jefferson Ortega. It's a novel paradigm to improve emotion recognition in ASD individuals. The epilepsy study will be looking at photobiomodulation by Dr. Richard Fry to look at the efficacy and safety of photobiomodulation and whether it can actually help epilepsy in patients who have epilepsy in ASD. It provides a novel treatment for epilepsy and epileptiform activity that reduces in neuroinflammation and brain connectivity, and also seeks to address the need for treatments in the older ASD population with epilepsy. So those are some of the studies. The other last one is behavioral exacerbations in autism, looking at blood-brain barrier dysfunction. This is the Stanford University study by Dr. Ian Mondal to characterize the unique subset of patients experiencing acute deteriorations resembling PANS and investigating the impact of plasma from these patients on the blood-brain barrier function. So these are past research studies that we have funded. I'm not going to go through this now, but just to let you know the range of studies that we fund. If you're interested, our annual conference, Synchrony Symposium, July 12 to 14, you will be able to come and hear updates from all these researchers. And on Sunday, we have a public day where we have streaming and in person. So please sign up, go to our website, brainfoundation.org, and please register so you'll be informed of all our activities. So just wanted to interrupt the talk and talk about this. So let's go back to question and answers. I have received some Q&A, so we can go to that. Or Dr. Krigsman, were you able to look at the Q&A questions here?
No, but I will now.
Yeah, if you click on Q&A, you can see the questions.
Got it.
I can also ask you some questions that have come in prior to the
Right. Okay.
conference. So one of the questions is, what is the main reason for acid reflux and throw up, despite no pathogen findings, and how can it be prevented or treated?
So, okay. So, well, first of all, for those of you wondering why I'm not so adept at Zoom, is I'm a Skype guy. Okay. So 25 years ago, when we had to develop a way to speak to our patients who weren't able to come in person, the old Skype was the first, if you all remember that far back, and I kind of stuck with it even through COVID. So so bear with my Zoom my Zoom ignorance. Having said that, the the reflux is you should think of reflux as a symptom, not a diagnosis. Meaning something is causing a patient to reflux. So you can reflux because you have an ulcer in the esophagus. You can reflux because you have an ulcer in the stomach. You can reflux because you have gastritis. You can reflux because you have inflammatory bowel disease. You can reflux because you have ulcers in the duodenum. You can reflux because you have a parasitic Giardia infection. So those are all reasons to reflux. And that's why I say if you want to try a trial of an empiric therapy for reflux like an acid blocker, it's okay to do it for a couple of weeks. But if it doesn't go away, then you got to find out which one of these and others, there are other causes also, might be causing it. And that may very well require an upper endoscopy.
There is a question on what is meant by deceleration of linear growth. Does it mean lack of height spurt during puberty?
So deceleration means that of linear growth means that when you look at the growth chart of a child, then what's considered normal is that you have the percentiles, and any individual given child will maintain pretty much the same percentile or pretty close to it over the years of their growth. Deceleration means that if when you're 4 years old, you're at the 80th percentile, let's say for linear growth for height, and by the time you're 9 years old, you're at the 30th percentile, then that means even though you may have grown into that there may be some growth, but the rate of growth has slowed down. And that's deceleration. The rate of growth is slowing down. And that's in pediatrics, major changes of growth, whether it's positive or negative, there are always indications that something is wrong. There could be lots of different causes, but it mandates an investigation.
I think the question also asked about adolescence and the growth spurt expected during puberty, and if that
Ah,
doesn't happen, is that deceleration?
okay. So on a growth chart, the growth spurt is taken into account. So when you look at the growth chart, the percentiles where a girl or a boy of any certain age should be um, uh, during puberty, those percentiles actually become more steep. So that's built in. It's built into the growth curve. So the answer is really still the same. If there's deviation, significant deviation from pre-established growth trajectories, that's pathologic. And the question is why?
The next question from Dr. Richard D. Have you found any particular role for IL-17 in GI inflammation? It has been proposed to link GI and brain function.
Um, First of all, hi Dick. It's great to see your name in the list, and I look forward to seeing you again in person, hopefully soon. Um, I haven't searched for it. We The work that we've done in our lab hasn't, as of yet anyway, been searching for specific cytokines. We haven't been doing that particular work. It's something I'd be interested in because I alluded to this before, and you apparently honed in on it, is that I think that in autism, um, the newer biologic drugs that attack specific cytokines uh, and in the process promote healing of whatever disorder you're dealing with. Um, that's kudos to pharma that discovered the cytokine, or in academic medicine. Mostly, it's been pharma that's been finding these cytokines. I believe that in autism there is a cytokine, a molecule, a cell, a series of events that are happening, that if we only knew what it was, we could block it. Um, it turns out that those cytokines, cellular functions that are active in Crohn's disease are also active in this disease, and that's why it does help these patients. I do believe that could be helped even more if we were to find that, but we haven't investigated whether IL-17 is active even in the GI tract.
Question from Carla. Thank you so much for guiding us through your clinical experience. Are you able to detect autoinflammatory syndromes with the biopsy in these kids, and how often is amyloid A elevated in serum? Are you able to test it?
I do not know how often amyloid A is present in serum. I just haven't focused an interest in that question, but I could get back to you and let you know. What was the first part of the question?
Are you
Here we
able
go.
Are you able to detect autoinflammatory
Here we go.
syndromes with biopsies in these cases?
Um, the answer is yes. The answer is the larger answer is yes. It's a tricky question because there's no biopsy that tells you that it's an autoimmune disease. We know it's autoimmune is if we don't find any immune trigger after a thorough, exhaustive search, then we say it's autoimmune. But there's nothing unique about patterns of inflammation necessarily that makes you say that this is autoimmune, that it's a diseased immune system, as opposed to just an unknown pathogen. So that's an answer that we don't know. My suspicion is that as I've mentioned, is that the disease that we're seeing in the GI tract is autoimmune because we haven't found anything, and many people have looked at the possible role of pathogens, either parasites or viruses or bacteria, and doesn't seem to be there.
I just want to add that in some of the older kids, you do find IBD similar to Crohn's, so maybe there is autoimmunity.
Yeah, no, I'm sure that there's autoimmunity even in the younger ones. Yeah, I think the question was, can we see are we able to determine that it's autoimmune from the biopsy? I think that was the question. Um, and no, the answer is that you don't know that it's autoimmune unless you see the disease, you see it over and over and over, and you never find a triggering antigen.
Next question, can IBD be treated completely or does the person have to be on medication for his whole life?
Great question. That's a great question. It's a question that I think every single parent asks. So it was interesting that over the years, what I found is that that this disease, this inflammatory bowel disease, that's ASD-associated, really has the same pattern as we see in Crohn's disease. That in Crohn's disease, we know, and similarly in this disease, there are some people that need to be on medications their whole life. The second you stop their medication, the disease comes back because we're not curing the immune system. We're just suppressing the inflammation. And then there are some kids with this disease and Crohn's disease that you get them in remission, they're symptom free, and then parents want to remove the medications. And although I don't encourage it, I don't discourage it either, because for all I know, they may not need it, because there are some patients who go on for years after stopping all medications and they remain symptom free, and I don't hear from them ever again. Then there are patients who after 10 years or 12 years, um, I get a note after not having any contact with them, and I see a picture of them at their high school prom, you know. And then there are patients who can go off it for a year and then the symptoms come back. And then there are patients who even as we come down, never mind stopping it, even as we come down, symptoms get worse. And Pramila may have a word or two to say about that. Um, so there's really a mix, just like you see in Crohn's disease, which is also very heartening when I saw that, because that means that this disease is behaving like other autoimmune diseases that we're familiar with.
Yeah, my personal experience is, as Dr. Krigsman said, it's similar to Crohn's in that there is a relapsing remitting sequence. But like he would say, the longer he's on remission, the next time I have a relapse, it's not that bad. The severity goes down even though there is a relapse. So if it's treated well, I think eventually the relapses get less severe. That's my personal take on that.
And that's a general finding. Yeah.
There
Okay,
are
let me
certain number of
see.
children with IBD who do not respond to therapy, immunomodulators, immune suppression, biological agents. What options do we have?
So if in fact everything has been tried, then everything has been tried. Um, but like I say, if it's an older child, over 17, there are so many medications out there. It's hard to imagine that in ASD they've been through all the possibilities. But let's just say, hypothetically, that you'd have someone like that. If someone came to me and has tried every biologic, every immunomodulator, every type of corticosteroid, every combination, and it didn't help, the next thing I would do would be to do an exclusive elemental formula feeding. I'm assuming that they haven't tried that because that's very hard to do with these children. It doesn't the formulas don't taste good. An elemental formula is a formula which doesn't contain any proteins. The proteins are all in the forms of individual amino acids. And what I would do with that kind of patient, and I have a few patients who we've done this with to great success, patients who just didn't respond well, and rather than going through 10 medications, I told the parents we could put a gastrostomy, a feeding tube in to the stomach, and we don't need the child's cooperation to drink it, and we just give them that formula, and it's amazing, but more often than not, it works because the inciting agent. That's part of why I say the inciting agent is really a protein, not, in my experience, not a carbohydrate. Um, I have a number of patients who can't come off the formula. In other words, and the kids love it. They're thrilled because they feel good. They finally eat and don't feel sick afterwards. Um, and the concern about pulling out the tube that so many people have with these children, I haven't had a single patient that pulled out their tube because the kids know. These kids are intelligent, as you know, they're very intelligent. They know that they finally found something which doesn't make them sick, so they don't pull it out. But that would be, I think, the last thing I would try, only because of practicality. Um, if it was me, like personally, if I was the patient, rather than trying 6 or 7 different immune suppressants, I think I would try the feeding tube first on myself. Only because rather than putting a drug in myself, I'd rather put a food in myself. Um, but again, that's something which is very difficult for uh, for parents of young children to really wrap their minds around and embrace. Um, so I'll always mention it in my more difficult patients, but that would be the hypothetical answer to your question.
I would also say that new drugs are coming out almost every year. So to,
Yeah.
keep looking into that. I'm going to combine a couple of these questions that are related to most GI doctors will still not do anything about this in spite of the patients talking about it. So my question would be, um, is there any article or anything that we could present to the GI doctor at an ER or any other GI doctor that could say that there is a higher comorbidity of bowel disease in autism, so therefore that it should not be ignored? So that's one question. The second comment is that we do plan to somebody asked for guidelines. We do plan to post patient-focused guidelines on our website on GI and seizures and all these different topics about what can be done proactively. So we will cover some of these topics with the consultation of Dr. Krigsman. So please look forward to that in our website. We will send out an announcement. Yeah, so going back to, is there anything that you think that would be useful to convince a gastroenterologist to look deeper?
So that's, you know, that's Well, the very first thing is that's why I included at Pramila's urging the first few slides. The way that any pediatric gastroenterologist is trained to approach specific problems, diarrhea, constipation, abnormal stools, growth issues. There are known approaches that have been honed and perfected over the years. Um, what needs to be done is you have to close, as a physician, you have to close your eyes to the autism part. And that's, I think, what most parents bump up against. They walk in there with their child, and even if the symptoms are jumping out at the physician often sees autism and then just loses interest because I don't know. You can ask each doctor why they lose interest. Um, uh, but that will be the best piece of advice is that you approach these children the same way that you would approach their medical problem if they did not have autism. That would be the way to do it. And again, and that's well known. And those were the first slides that I showed. Did I answer the question? Um,
There was an old clinical guideline document where it talked about comor. There was a summary of a roundtable that we are trying to again continue at the
yes.
Brain Foundation.
Yeah.
Yeah, so
Okay. So your other question, right? So the other part of the question was, is there um any published evidence that GI disease, not even speaking about a specific GI diagnosis, the fact that GI problems is the term that the medical literature uses is it or is it not more common in ASD than in non-ASD children? And that there are so many papers that go back and forth for years and years and years, from 1999 until 2014. There must have been 30, maybe more, papers on both sides of the fence. Different quality papers, but some said yes,